Okay, there's a wrinkle here. There's a big wrinkle on age. Anyone tell me what my big wrinkle is going to be? Hello, Elias. What's the big wrinkle on age? Oh, this is good. Nice. Richard just loves this. Richard loves these puzzles. He's always convinced he's going to figure it out. It's so cute because, of course, you have to be told once and then it's easy. Okay, anyone see what the wrinkle on age is? You ready? Ah, that changes everything. Because the second you care about babies, where are we? We're into female reproductive as the reproductive end of it. So now we're not talking about females in the 30s with joint pain. Yeah, got it. That's autoimmune. The second you see the G's and the P's show up, that's totally, now we're in OB, right? Okay. So when I say I'm into female endocrine or OB, now you're going to take the age and you're going to translate it. So the second you see the age of a female and we're talking something to do with endocrine or OB, you're going to break it into where is menarche? Are they pre or post menarche? Are they in reproductive? Perimenopausal, that's when you see all of it. They all start getting anovulatory cycles. And postmenopausal. Because then they just become guys. Okay? So whenever you talk about this, all of a sudden you translate the age. So when I see 34 female G2P2, I'm saying reproductive age woman. Okay? So when you say female reproductive, then you're going into, what problems are we going to see here? So now you can see, oh, here we go. We've got two that we can talk about, but here's one of them. And that's a common. So when you talk about female endocrine, there are three great differentials you have to be able to do in female endocrine. You've got to be able to do infertility. You've got to be able to do primary amenorrhea. And you got to be able to do secondary amenorrhea. Okay? So when you say, how do I learn female endocrine? Then we go to drugs and tests. If you can do 3 drugs and 2 tests, it means that you can do most of female endocrine. And you guys really don't get taught it because it kind of falls into the cracks. You know, your PhDs don't teach it. Your OBs don't really know it unless you go to an infertility clinic, and then it's a really big deal. So when you say, what are the tests that I've got to be able to do? So when you come over here, what are the tests I need to do in female? You've got to be able to tell me, what is a day 3 FSH? That's a big, big idea. The second thing you got to do is a day 21 progesterone. You got to explain to me how you use birth control pills. Because there's a lot of female endocrine there, and you got to be able to map it all and show me how that works. You've got to show me what clomiphene does. And you've got to explain to me leuprolide. And my sense of it is, having taught this a while, if you can walk through all the things of why I can explain how and when to use them and why they work, my sense is you can do most of female endocrine. Okay? So here we are here. We can see, here's our first choice of differential, which is this one. So we got to talk about that for a sec. But we have a second one, don't we? So we got a second differential. So what's that going to be the differential of?
Secondary.
That's going to be the differential of galactorrhea, isn't it? And there's really only one way I get galactorrhea, isn't there? When I say galactorrhea, it's really the differential diagnosis of, right, hyperprolactinemia. Okay? So you can pick whichever one of these you want to do. I don't see any way to pick. Just before we leave, what does citalopram do?
SSRI.
Okay, so is that one of the drugs in hyperprolactinemia?
No.
A little bit, right? It's not common, but it's mostly the antipsychotics that we're talking about, isn't it? Okay, so let's just take a look and let's just walk through the algorithms, and they'll give us a sense of where we want to go next, won't it? So let's do infertility. What is infertility?
12 months of trying to have a baby but being unsuccessful.
Thank you, Alex. That's great. What is the thank you. Now I'm going to get lawyerly. What is the definition of infertility?
Attempting to conceive, but not successfully within 12 months.
Is he right? It depends. It depends, doesn't it? If you're talking about a 19-year-old, 2 years is fine. If you're talking about a 30-year-old, yeah, I would make it shorter. If you're talking about a 35-year-old, when women drop off the fertility cliff, 6 months, let's go. Okay? So when we talk about infertility, what is this woman's age? Yikes. Right? That's what she's approaching the cliff, isn't she? So it turns out, Richard, there isn't a precise definition. If you need a working rule of thumb, 1 year is a great rule of thumb, and I would have given you full credits for that, right? But it's not written in stone, and it's not magic. You know what it was in my day when everyone got married between 20 and 22? It was 2 years. 2 years of unprotected sex and to do it, okay? So when you talk about infertility, remember there's female and there's male. Now you'll read, most people say 1/3 female, 1/3 male, and then 1/3 both. That hasn't been my experience. My experience is it weights more to females. They have much more complex plumbing and they have a much more complex endocrine. But nonetheless, that's the party line and that's perfectly fine. Okay, the first thing you do when you do infertility is you're going to do a day 3 FSH. Why is that? Has everyone got a picture of endocrine in their brain? Everyone can see the normal cycle going from every time I say this, every time I say female repro, right? So every time I say female repro, I'm assuming you got this. So the hypothalamus is going to release gonadotropin releasing hormone. The pituitary is going to release FSH and LH, right? And the ovary is going to release estrogen and progesterone. And they're both going to come down here and affect lots of different things, but we summarize it all in the endometrium. It affects cervical mucus. It affects endometrium, proliferative secretory. It affects the fluid from the fallopian tube and the speed of the cilia. So it actually does the whole system, but nonetheless, we summarize it all in endometrium and that's fine. Okay, so when I say, what does a day 3 FSH teach me? So what is the definition of day 0?
First day of menses.
Okay, so day 0 is the first day of menses, and in a stylized 28-day cycle, ovulation at day 14, right? Remember, the best fixed part here is this is the fixed part here at 14 days. A lot of variation in the earlier part, okay? So when I come up here and we map out each part of it, this is going to be the start, right? I'm going to start up here with the H, and I'm going to see the beginning of my gonadotropin, which is, so it's going to go up. And remember, it is pulsatile. And that's then going to start by driving my FSH and LH. Well, okay, but help me out here. I've only got one gonadotropin releasing hormone, right? Right? And it's going to a single cell in the pituitary, right? So how do I get 2 products? So how do I get 2 products? So the second way you can signal is pulsatile by frequency and amplitude. So when you say, what am I going to get? In the second half of the cycle, I have low frequent altitude. That's going to be FSH. And when I'm ready to switch over to LH, I'm going to have high frequency, low frequency, high amplitude, and that's going to drive me to LH. So remember, when you see a hormone signal, there's some famous examples in the body where pulses can vary by amplitude and frequency and change the signal. Can anyone tell me the other famous example? Okay, PTH. I have a high PTH. I resorb bone through my osteoclast, right? Right? Yeah. But when I use PTH, I also stimulate the osteoblast to lay down bone. Well, WTF? And the answer is, if you have a short, high burst, a short, low burst, that is for the osteoblast and you will lay down bone. If you have a high, sustained burst, that will produce rank and you'll get bone resorption. So when I say PTH to the osteoblast, you got in your mind say, well, what signal am I getting? Because a small, brief signal will lay down bone, and a high, sustained signal for hours will resorb bone. Okay? So that's just, if you haven't thought about how the endocrine system signals, it's kind of interesting to do that. Okay, so then we're going to have our FSH, and we're going to come down here to my estrogen, right? And so my estrogen is going to come up and do this. And then I'm going to have my LH is going to have here my LH surge. And that's then going to be giving me my progesterone here. Okay? And remember what happens when I do my ovary. I go from a follicle here, I go over here to my corpus luteum, right? So when you're building in that ovary, remember, estrogen is coming from the follicle, progesterone is coming from the corpus luteum. So if we need to walk through this, you let me know and we'll walk it through. That's a fundamental understanding. And then my estrogen is going to be my proliferative phase in my endometrium, and my progesterone is going to be my secretory phase. Okay, so if you can't draw that picture out, I'll send you the picture after class. Practice writing it out. It's how you think of all female endocrine. Okay, so what does day 3 FSH teach me? What does FSH do? Does two things.
Stimulates the follicle.
Okay, so the first thing we talk about when we say FSH, if it's follicle stimulating. So no one's quite sure how it picks the follicle and how it chooses which one goes on, but that's true. But the second thing is, look what it's going to do. It's going to come to the ovary and it's going to stimulate estrogen. So when I say to you, give me a follicle, do you have a picture in your mind of what a follicle looks like? Okay, let's just come down here and make sure you got a picture of how that looks. So if here's my ovary and here are my follicles, right? When you take a look at what a follicle looks like, this is the picture you want in your head. Here's the follicle, and it is lined by my granulosa cells. Okay, so here are my granulosa cells lining it. And in the middle of that, there's going to be my egg. And then surrounding this are going to be my thecal cells. So every time you say ovary, that's the functional unit of the ovary. So my LH stimulates the theca, and the theca makes androgens. The FSH is going to stimulate the granulosa cells, and they're going to take the androgens and make estrogen. So don't just write magical words. When I'll send you the picture, make sure you can draw all of this out so you can see the hypothalamus, you can see the anterior pituitary, you can see the follicle in the ovary with granulosa cells and thecal cells, and then in the endometrium, proliferative to secretory. Okay, so that's worth practicing. Okay, so what would it mean if the follicle FSH was really high? If it is high, that means you have ovarian failure. because there's no estrogen, progesterone to inhibit it. So remember that in all of our endocrine, it's a feedback system. If you don't get feedback, the signal gets higher. So FSH that's elevated is the marker of ovarian failure. Okay, Eliasa, you're now a physician for my daughter-in-law. She's a delightful 29-year-old lawyer married to my son, and they've finally gotten married after cohabiting forever. Drove me crazy. So they finally get formally married, and 6 months later, she says to me, so I'm not pregnant yet. Should I get myself worked up? And this is a true story. Should she?
How old did you say she was?
29. Perfectly well as far as we know.
Might be a little early. Probably a little early. She's only 29.
Absolutely go get worked out. What the hell? What are they going to do? What are they going to do as the first step in her workup?
I guess they could check the FSH.
Absolutely, friggin' day 3 FSH. Of course you would do that. Okay, so if a day 3 FSH, if abnormal is greater than 40 whatever units you pick, and normal is less than 5, you know what she was? Right there. She was 18. What do you think now?
Seems a little suspicious.
She's going into ovarian failure, isn't she?
Yeah.
And so she was speaking to her mom about this, who said, oh, yeah, your Aunt Tilly, yeah, she went through menopause when she was 34. And, you know, I think I did too, now that you mention it. Thanks, Mom. Okay, so what are you going to recommend, Eliasa?
I don't know.
Okay, think through the picture. Why is your FSH high?
Because she's not getting the feedback
So
from
what hasn't she got?
estrogen. So I guess you could.
So what hasn't she got? Follicles.
Yeah.
She's running out. She started with 1 million, and you know you're going to use about 40,000, and she's running out.
Mm-hmm.
So what should she do? Don't waste them.
Yeah.
Every egg is precious. So what's the best way to capture those rare and valuable eggs? Right? So she went into IVF. So what they're going to do now is they're going to capture her endocrinologically. They're going to ultrasound to see the developing follicle, and they're going to do micropuncture technique to capture her eggs. You know how many she has left? 12. She had 12 eggs left. And so she went through her first cycle and it failed. And she went through her second cycle, and month 4, it was a take because they followed the hormones. What hormone did they follow for the take? So how do you know it was a successful implantation?
Progesterone.
Progesterone. Yeah.
Oh my goodness, we have to build this
HCG.
discussion here. Okay, well, we have to talk about this. You haven't got a good image here. You're going to follow HCG.
Mm-hmm.
So her HCG took off great. So they didn't worry about it until about month 4. And they were doing the ultrasound. Obviously, it's a very great, very specific skill. And they turned to her and said, so how do you feel about twins? Okay, so when you think through, because you're going to deal with a lot of professional women, aren't you? Right? And they're all going to put off their 21-year-old fertility till the right time. So this is a really important discussion for you, isn't it? Because you're going to be dealing with lots of this discussion. Nothing wrong with pulling an FSH. Why not? And can you see how useful that is? Okay, if it is normal, the next thing we're going to do is a day 21 progesterone. Why? Well, how do you get progesterone?
Corpus luteum.
And how do you get a corpus luteum?
Rupture.
Ovulation.
Because you ovulated. So you had an LH surge and you ovulated. So if you have progesterone that's high at day 21, what does that prove?
You have
that
a
you did
corpus.
ovulate.
Ovulation. Okay. So if you've got a working ovary, the next thing you say is, yes, it's high. You know they ovulated. If it is low, they did not. So what's going to be the commonest cause here? 8% of all American women.
Well, anovulatory
PCOS.
cycles.
PCOS, right? Okay. So as you go through this and you think about what am I studying to get ready for the friggin' exam, I guess you're pretty good on ovarian failure. That's a nice, easy get. But the big number one cause in America is PCOS. Okay. After that, you know what we go to? We go to other endocrines. And what are going to be my two commonest endocrines that I'm going to find for infertility?
Diabetes.
No, actually, they're not. They don't have trouble getting pregnant. They have trouble with the maturation of the placenta. So they tend to be a fetal placental insufficiency third trimester. So yes, so that's not a problem for fertility, getting pregnant. That's a problem of fecundity. Fecund is the ability to produce a live offspring. So they're fertile, not fecund. Okay? So it's going to be
Hyperpituitary?
thyroid and prolactin. Obviously, all the endocrines come in there, but you know me, everything isn't equally important. Well, so here we've got galactorrhea, and there's prolactin. So that's looking pretty good for this patient, isn't it? Okay? And if they've ovulated, what's the next thing you're going to do? You're going to do a hysterogram. Because the next commonest cause is going to be tubal block. Why is that so common?
So PID, like
Yeah, right. 70%, that's a very nice answer. 70% of chlamydia and gonorrhea is asymptomatic. That's why you do that culture or nucleic antigen amplification test every friggin' pap smear, right? Because they don't know. After that, it's complex, but most of the time you're going to laparoscopy. So this gets us to the long list, but you know what the next one on the long list is? Is endometriosis. So when you do getting ready for infertility, this is how you're going to do it in your mind. 1, depending on your population, 2, and 3. So when you think through the diseases you're really going to have a good handle on, those are really critical diseases. Okay, what's the clinical presentation of endometriosis?
pain.
No, when?
When your or menstrual cycle pain.
When you're pain, right? Pain with menses is the key, right? And there's no way to fake that. It's pain with menses. Okay? Okay, so you're happy with this lady? We could do an infertility workup, right? And with our galactorrhea, that's looming pretty large, isn't it? The second thing we could do is we could talk about hyperprolactinemia. And to talk about hyperprolactinemia takes me to this. This just happens to be the best test I have for teaching. Now, remember, we've already talked about what you have to see in your mind's eye. So when I talk about the hypothalamus and the pituitary, I expect you to be able to draw this picture. Here's my corpus callosum. Here's my fornix. Here is my optic chiasma. Here's my anterior pituitary. Here's my posterior pituitary. All these cases going through in your mind. Here's my mammillary body. Whose name just came to your mind?
Wernicke-Korsakoff.
Right? Wernicke's is?
Thalaplegia, dementia, and ataxia.
And it's acute. Right? And Korsakoff's is chronic confab. Nice. Then we're going to come over here and we're going to drop into our midbrain, pons decussation, medulla. And then we're going to finish it here. There's my pineal. Who are you thinking of?
Paradigm.
Right? So in addition to sunset eyes, what are you going to get?
Headache.
Right? Isn't that just nice? There's my tectum, and then there's my cerebellum. Who pops into your head?
Childhood tumors.
Right? Infratentorial, right? And how are they going to present?
Headache.
Headache, and it's cerebellum, so
Ataxia.
ataxia, right? And then we're going to finish off here. And that's going to give me my 9, 10, and my best friend, nucleus tractus solitarius. And there I'm going to pick up my sympathetic nervous system. So that's a really good picture, right? Lots to talk about in that, because this is going to be my thalamus. What orifice is that right there?
Where?
Right here.
Oh, Raymond of Monroe.
Right, because remember, this is the midline view, so that's where you're going to swim out into the lateral ventricles, isn't it? So then this becomes my hypothalamus, and it's a complex structure that they do have typically one question on the exam, but I always do my supraoptic, right, paraventricular, and then my arcuate, and that gets most of the work done that you need to signal to it. Okay, when I say how do we think about, what are my two diseases here in the posterior pituitary? DI, so there's my polyuria polydipsia, and then and if it's too much, I think about it as acute and chronic. So acute is my thoracic surgery post-op, but my chronic is the classic question of hyponatremia in my lung cancer patient, right? So yeah, and so these are all really standard stories in medicine because they're really common. This is just how you're always going to build it in. Okay, so now what we're going to do is we're going to come down here and we're going to talk about, let's talk about the signaling from that, because this is how I like thinking about hyperprolactinemia. Okay, so when you see this picture, this is a really valuable way because there's my hypothalamus, right? And what we're doing now is drawing out the signaling. Okay, what disease am I going to think about when I do that structure right there? See, I did that little portal vein right there.
Sheehan.
GN.
Sheehan's.
And Sheehan bleeding after pregnancy.
Oh, very nice. I like that. Sheehan's. What did you say, Sheehan?
Mm-hmm.
Okay, I'm going to get my ears checked. So yeah, so that's how we think about Sheehan's, right? Because as Richard will say, it's hyperplasia in a confined fixed space and then a venous pressure blood supply. Okay, what do you need to know out of this signaling? So we're going to be talking about hyperprolactinemia. Well, look at this. Here's the first thing to pay attention to. TRH stimulates the lactotroph. So when we talk about causes of hyperprolactinemia, obviously we're going to put in there, one of the first things we're going to put in is hypothyroidism. Okay? The next thing to look at is this right here. It's the only signal that's inhibited. So how do you differentiate panhypopit from damage is whether they get galactorrhea or not. So when we do that one right there, that's going to be anything that damages the isthmus. And one of those causes could be my pituitary adenoma. So you can get hyperprolactinemia two ways from a pituitary adenoma. It can just make it. So there's my pituitary adenoma. It can just make it. But it can also block the isthmus, and then I've disinhibited it. And then the last cause is going to be my drugs, and these tend to be your antipsychotics. It's a long list, but they tend to be your antipsychotics. Okay? So when I have this patient coming in complaining of infertility, well, then you got to give me the feedback. So how does prolactin cause infertility? So if I'm going to do my HP, what organ am I going to draw for prolactin?
Prolactin's coming from the anterior pituitary. And
but what organ is the end organ signal for prolactin?
It's working on the breast.
Right. So it's on the breast, right?
Yeah.
So when I say, how do you think about the breast? What are you going to draw me?
Ducts and lobules.
Okay, so there's my lactiferous sinus going to my ducts, and then if it's a lactating breast, there's going to be 12 to 18 lobules, right? And when I take a lobule and you say, how do I think about the breast? You're going to draw your lobules this way. This is the functional unit. I have my milk secreting cell, and then around it, I have my myoepithelial cell. So the signal to my lactating cell is prolactin, and my signal to the myoepithelial cell is oxytocin. Okay? So when you say, how do I get my galactorrhea? Well, obviously, I stimulate the prolactin and females. Do males get prolactin? Do they get galactorrhea? Now, there are rare cases. It's like, aha, well, there you go. That's something new, because they don't go through enough of the estrogen progesterone cycling to even be in a state where they can be stimulated by prolactin. So it is described, but it's not the way you think of it. Okay? So when I draw my picture here, prolactin is going to do this, right? It's inhibitory. There's my oxytocin. That's then going to give my prolactin. And here's the bitch. It's my prolactin that inhibits. Okay? So when you look at this, remember then that's going to be, what do you look for in the male? That inhibition does everything. So you're going to see also a decrease in your gonadotropins. So in males, you don't go looking for galactorrhea. In males, you go looking for low testosterone. Okay? Okay, so there are two ways of looking at our patient here. You can go in for the infertility, or you can go looking for the increase in prolactin. Okay, so what do you want to order next? Got it. So we've got our two pictures. We've thought through our causes. What do you want to do next?
Prolactin level?
Okay, we can do a prolactin level. Excellent. Anything else you want? So, yep, let's do that. I think that's a really good suggestion. Anything else you want?
You get a TSH level.
Oh, for sure you would do that. Absolutely, you get a TSH. But remember, is prolactin physiologic? And what's the single biggest physiologic stimulation of prolactin? She's trying to get pregnant. Wouldn't that be embarrassing? Right? So there's a rule that we used in all our ERs, which said a woman of reproductive age, every woman of reproductive age is pregnant until proven otherwise. So you couldn't come into any of my hospital's ERs. If you were menstruating, we would always get a urine HCG on you. Okay? That's just one of those really good rules to build into your head, and that would perfectly apply here. Okay?
Prolactin adenoma, secreting adenoma.
Okay, so remember we talked about prolactin has 4 causes, right? So we've ruled out thyroid. That's pretty nice. We've ruled out physiology. That's pretty nice, right? Number one, so you're saying it's a secreting adenoma, right? But where else could that adenoma be that would cause increased prolactin, Alexander?
You mean
If
like
it
a
was
perineoplastic?
non-secreting, where could it be?
Damage, infundibulum creating.
Right, so it could be in the infundibulum.
But you would also have low thyroid.
Well, but we don't have it here because we know our TSH is normal.
Right.
So our testing's ruled that out. And then we don't have any drugs. So that's really going to be our two choices. One of the rules you're going to learn in medicine is all highs aren't created equal. So anytime you're measuring any test at all, if it's only up 2 to 4 times, yeah, that leaves you a pretty broad differential diagnosis. You should be thoughtful when you get it's up, but man, anytime it's 10 to 20 times, that's good enough to be diagnostic. Of neoplasm, okay? So if I just had a little bump in prolactin, I would feel circumspect. Man, that's a doozy. That's 10 times up. That's going to be an adenoma. So if I had to bet, you're going to bet on that just because it's so high. You know, if I have a liver mass and I go looking for my alpha fetoprotein, if it's up 2 times, does that prove it's a hepatocellular carcinoma? If it's up 40 times, is that diagnostic?
I would say
Right?
yes.
That's right. So remember, all things aren't created equal. If I'm looking for someone with multiple ulcers in their duodenum refractory to treatment, and my gastrin's up 2 or 3 times, is that a gastrinoma? Maybe. If it's up 30 times, is that a gastrinoma? Absolutely. So remember, not all numbers are created equal. You got to use a little judgment in that. Okay, so what do you want to do now? Okay, so that's our bet. What do you want to do now?
I would get an MRI.
Sorry, you got us. Is that an MRI or a CT?
MRI.
Right, because it's got the space. Okay, good. So what'd you find?
It looks as though there
Okay.
is a mass, probably like 2, 3
Is that the biggest
centimeters.
damn thing you've ever seen in your life? Even I picked it because even I could find that one. Okay, so that's a really nice looking mass form there, right? Okay, if it was a little 5-year-old, what if it was a little 5-year-old boy?
I
How
would
that
want to look
change
for calcifications. I'd be concerned.
Nice,
with
Richard.
craniopharyngioma.
That's exactly right, isn't it, Richard? Because there's your craniopharyngioma. How would you, if he had acute symptoms, Richard, how would you treat it right off the top while you were thinking through what you had to do?
If there were acute symptoms, then I would say probably go to surgery. But if there's nothing, or when we talk about acute symptoms, like if we're talking about, say,
Visual defects, disabling, involving other cranial
Okay.
nerves.
something like that, then I would say maybe the first step is put the patient on cabergoline or bromocriptine. See if that does anything.
Nice. I like that a lot. How can I relieve the pressure mechanically?
I would say maybe
Because you know this.
probably some kind of centesis of the sinuses.
Well, no, think about this. If I said to you, what do you grossly find in a craniopharyngioma? You'd say calcification on x-ray, and what do you find in the tumor? You know this.
You're going to find glandular tissue.
Keep going. What did I just write?
Motor oil.
Right? You knew that, right? It's a cystic structure that has this very distinctive, it looks like your dad's car oil, right? So what does that tell you if you've got pressure symptoms?
Just drain that.
You can drain the sucker, and that buys you all the friggin' time in the world, doesn't it? So now for the first time in your life, you actually care about motor oil because it tells you that it's cystic, and that gives you a mechanical option for acute care. Okay, so that's pretty nice. And then look at how we talked about how this is the standard view that I just drove for you, right? Look what we got here. Who's that bad boy? Right? Who's that nice guy there? And then you drop down, and there's my pituitary. Yep, sure enough, there's my mammillary body, right? Here we're coming into my midbrain. There's my pons decussation, and there's my medulla. Oh, look what's calcified right there. Yeah, that's a pretty little pineal, isn't it? And doesn't that just sing to you now? You go, oh, you pretty little pineal, that's gorgeous. And then here's my tectum, and then, oh, look what I got here, right? And oh, by the way, it's infratentorial. It just speaks to you, right? And then you know perfectly well, can I draw cranial nerve 9? Because you couldn't before you drew it for yourself. But now, isn't that just the most obvious thing in the world? And if I said, well, there's 10, well, they got to be related because they both go to the nucleus tractus solitarius. And all of a sudden, it isn't memorizing. It's a way of thinking about your patient. Okay, everyone happy with that? Okay, how are you going to treat it?
Depends on the size.
This one.
Transsphenoid resection.
Okay, so what picture of anatomy do you need for a transsphenoid? So there's my sphenoid space right there, right? When you think through what you're going to do, how do you think of that transsphenoid space? Because it's one of the classic pictures in anatomy. Okay, you're going to draw a bit of skull, and then you're going to drop in and I'm not drawing tissue, I'm drawing bone now, right? So that's going to be my sella turcica. You can call it pituitary, but that's what's in it. This is my sella before it, right? And then you're going to have a couple of lobes of brain, and then you're going to have your sphenoid sinus. Everyone recognize this picture? Right? Because this is my inferior petrosal sinus. Okay? And watch what we're going to draw in here. What are these structures right here? That's my carotid siphon. Those are my internal carotid forming the siphon. That's why you see it coming around, because it's this big hook, right? It's got that nice curve to it. And then what cranial nerves am I going to draw here?
6.
Well, let's start. Make it in order. Why make it hard on yourself? Okay, God, I'll start it. Fine. 6. Make it hard on yourself.
5.
Oh, God, you guys. Okay, but you can't just do 5. It's got to be
5. 1.
V2 and
One,
V1. Okay, now I guess you guys are all going backwards. So that's going to be 4, and that's going to be 3. Okay? Okay, one other thing I want you to see from this. So this is my inferior petrosal sinus, right? So this is a really famous picture in any neuroanatomy, PhD in anatomy worth his salt is going to make you draw this. But I want you to think through a clinical story. So we've done the arterial blood supply of the pituitary, right? Why do I care about the venous? Watch this. Because if I'm going to draw the veins in for you, the veins are actually all going to come out this way. And they're going to drain into my inferior petrosal sinus, right? So there's the venous drainage from the pituitary. You know what that drains into? You ready for this? That's going to drain into, just outside the sinus, it's going to drain into my jugular vein, okay? So that's going to be my jugular vein. The reason you care about that is that can be catheterized. So anytime you want direct sampling of the pituitary, you can literally catheterize this and put your little catheter right there, and you can do pituitary sampling. And that has completely replaced, in academic tertiary centers, that has now replaced your high dose dexamethasone for ACTH. Okay, so it turns out that's a reasonably important piece of anatomy. So there's my sinuses. Okay, when I do my transsphenoidal resection, what are you looking for as the commonest complication?
Loss of all the hormones.
Okay, so you can destroy the whole thing. So yeah, panhypopit I like. You're not going to be able to do lactation, Melissa. What's going to be your first symptom? Of all the hormones you lose, which one's going to show up the first? Because prolactin's not going to help you here. They're not pregnant, so
Thyroid?
it's not Sheehan's. Which one?
Thyroid? Oh, no, it's a cortisol. Lack of the
Right.
cortisol.
Okay. So you're going to be looking for blood pressure changes with that. That's going to take a week or two. Okay. So that's fine. So you're talking about the panhypopit. I think that's perfectly sensible. I've got a better one. What happens if I damage the isthmus? If I damage the isthmus, who shows up immediately? That's the first guy to show up if I damage isthmus, right? So what are you looking for in your patient? Polyuria, polydipsia. So you can see that all this anatomy kind of starts talking to you when you start actually imagining patient care. So you can see this nice 34-year-old woman, she's looking for her third child, she's oligomenorrheic, she develops galactorrhea, and you can see the pictures that you need to think through what she's going to be. Hypothalamus to pituitary. Then you can think through, I've got a nice algorithm for infertility, or I can do a hyperprolactinemia. Both are going to be fine. Then you say, when I do prolactin, how do I think about prolactin, right? And you're going to think about your prolactin in one of the very standard pictures of pituitary, right? You're going to think about TSH. You're going to think about loss of the isthmus, direct secretion, and then just hanging in there is going to be my psychotic drugs. And when you see your tumor, it's our beautiful standard median of brain. Doesn't that speak wonders to you? And then you say, okay, here it is. I'm going to have to come out of the sphenoid, and then that's going to be your standard transsphenoidal sinus picture. Okay, the only other thing out of this median picture I want you to pay attention to is that bad boy right there. Why do I care about that bad boy right there? So that's going to be my central sulcus. Why do I care about my central sulcus? Because this side is going to be motor,
control,
and this side is going to be
sensory.
okay. That's pretty fun. Everyone happy with that? So you can see we always set up endocrine as a feedback mechanism, and we always plot it against hypothalamus to pituitary to your organ. If I said ovary, what structure are you going to give me? A follicle with granulosa and thecal cells. If I give you prolactin, you're going to build me a breast with milk secreting duct and myoepithelial around it. So every time we set that up, there's our nice neck masses. When I say neck masses, what do you say?
Thyroid, non-thyroid.
Nice. And how do we differentiate them? Right, the water swallow test, right? And then everything follows. Gorgeous. Okay, let's just start one more. This is an easy one, and then we'll be done. Okay, right? So endocrine's always a pattern, and this is the pattern of
Hyperthyroidism.
hyperthyroidism, right? And when I say hyperthyroidism, it's all caused by, oh dear. It's all caused by, ooh, what are you saying, Elisa?
Thyroid hormone.
Oh, yeah, it's all caused by thyroid hormone. But what's my disease underlying it?
Graves.
Graves.
Okay, 90% is going to be Graves, which tells you on the physical exam, what do you want to have as rule in, rule out right now?
Bulging eyes.
Yeah, exophthalmos and non-pitting edema, right? Because the second you've got those, it's Graves and nothing else. It's just how you think about it. Okay, so let's talk about these symptoms and a way of organizing them, and then we'll call it a day, okay? So as always in thyroid, right, or any system, you're always going to set it up as hypothalamus, pituitary, thyroid. You're always going to do, there's my thyroid releasing hormone, there's my thyroid stimulating hormone, and there's my T4 with my feedback inhibition. You always set up every endocrine system as a feedback system. Okay, but how do I think about thyroid? Have you ever gone in and looked for the molecular basis of thyroid? You ever looked that up?
The first year.
It's not nothing. It's the crappiest read in the whole world. You sort of go, well, what the hell is the target of my T4? What the heck? And so I have to teach this, right? So it's not enough that we just memorize it. You always need a story to remember things. And you know what the greatest story about thyroid is? I'm not making this up. Evolution. Every time you think about thyroid, I want you to think about warm-bodied and cold-bodied animals. Because what you got to ask yourself is, how are we warm-bodied? And the answer is, warm body evolutionarily appears with the thyroid. And it turned out that it all started with catching iodine. If you're going to make iodine in the body, it turns out that modified this little mucus structure. If you go back to worms, but if you go back to worms, a lot of the worms have this little mucus structure that they use to trap microscopic organisms. And evolutionarily, that's why the thyroid's up here. That little trapping mucus gland was used to trap iodine, which was used to make thyroid. So the question is, how does thyroid keep you warm? And that brings us to a discussion of how does the body manage temperature? Isn't that great? Okay, so how does the body do temperature? Well, the first thing it has is it has a set point. No one has any idea why it's 98.6. No one can tell you that. It's just who humans are. You know how much variation there is normally in a population? You know how much variation there is in that? You ready for this? Holy crap. 3 degrees. So every time you confidently said, yep, temperature's 101, it's a fever, you sort of go, maybe. So you always want to do multiple temperatures on a patient. And then remember, there's lots of variation, which can be diurnal. Your temperature varies a degree during the day. It can be hormonal. Remember, when women are in the progesterone phase, it goes up 1 degree. That's why people use temperature either get pregnant or to avoid pregnancy. I know it's really hard for you to imagine this, but you know when the pill became universally available?
It still hasn't.
When? 1972. Now that seems like ancient history. I was born in 1952. Can you imagine that? And when during the early 60s, they suddenly realized that estrogen, they learned how to make it, that estrogen was going to really matter. Women had to go to court to be able to get estrogen and progesterone outside of medical therapy. And so you know what society said? Only married women. And they said that because if we de-link sexuality from pregnancy, next thing you're going to see, we're going to have babies born to unwed mothers and marriage is going to be a disaster. Well, they were right, but no one cared about that. So after a series of court cases, by 1972, that was when the pill became universally available to any woman for any cause. And believe me, you had to live through it to understand it. If you think that what we see now matters, you should have seen the wars we went through in the early 70s. It was like living in a science fiction novel when they said, you know, let's imagine if humans could fly. Wow, you've never seen it. We still haven't worked through the implications of this. So if you ask me, what is the single most important cultural biologic event in human history? I would say for our generation that are alive now, it's the pill. Man, someday when you get more time, you go back and read about what happens when you de-link sexuality from pregnancy. We still haven't worked that through. We're still learning about ourselves. It's a hell of a subject. Okay, so I actually knew women that used the temperature mechanism to either get pregnant or to avoid pregnant. That was a real thing when I was in high school. Well, I had friends' moms who did that, mostly because they didn't want to be pregnant. Works really badly, by the way. Okay, so there's the set point. Okay, how does the body know if the temperature is too low? How do you know if you're cold?
Shiver.
Well, no, a shiver is a consequence. How do you know to shiver? Isn't that great? Okay, you ready for this? It turns out there are 3 places that measure temperature. Your hypothalamus of course, everything is hypothalamus. Your hypothalamus directly measures it. You have a little tiny spot in the spine that measures it, but you know where most of the feedback comes from? Palms and soles. So if you are designing a house in a cold climate, you know what the single best thing is to manage the temperature? Heat the surfaces. If you walk on warm floors and touch warm counters, you can keep the ambient temperature down as much as 5 to 8 degrees because we mostly perceive coldness through our palms and soles. Okay? And the palms and soles, guess what they do? They go to the temperature center in the hypothalamus, of course, because the hypothalamus does everything. So when the hypothalamus says, yes, it's cold, what does she say? And shivering is second. What does she do first?
Vasoconstrict?
Yep, skin, right? It's through the skin and you vasoconstrict. And how do you do that? Sympathetic nervous system, okay? Second is going to be shiver to try to create heat, and that's it. Then you die. Then your core temperature drops and you're dead, okay? What happens if you're high?
Vasodilate.
Yes, you sure do. And how do you do that?
Parasympathetic?
Oh dear. Okay, and what's the signal? What kind of receptor is it? This is the sympathetic that is not, right?
Two? Or I don't know. Because alpha 1 vasoconstricts, so I would say, oh,
It's a totally different signal, right? It's a totally different signal. And then what's going to be second? Yeah, right? So there's the acetylcholine signal there for our sweat because it's a different signal. But you notice the whole thing is sympathetic nervous system. So every time you think about the thyroid, you're going to say to yourself, so how does the thyroid do the set point? Because you've got to create heat. And you know how it does that? It does that through two basic mechanisms. It renders all of the ATPases inefficient. And in the mitochondria, it uncouples. And so everybody has to run. And it's inefficient, and so you run harder, and it creates wasteful heat. And so the whole through evolution, when you take a look at warm-bodied, cold-bodied animals, the difference is whether or not you have a thyroid, and thyroid, oddly enough, makes you molecularly inefficient, but that creates a heat waste. Okay, just while we're here, how do babies uncouple?
In the brown fat?
Yep, and what's the protein?
Glean.
Thermo, heat, gen, to create. So it's thermogenin. So we have physiologic examples of uncoupling. So that's why when you go looking for, so how does thyroid work? You say to yourself, because it actually makes you inefficient. You have to have more energy to be warm-bodied, but then you're good to go when it's cold out. And obviously both systems work. It's a question of what your design is for. So when you take a look at the symptoms of hyperthyroidism, you can see that the first thing we're going to have is all the ones that are at increased basal metabolic rate because you've got all these inefficient systems. So the big ones for sure, absolutely specific, is going to be response to temperature. If you can't stay warm, you're hypothyroid. If you're way too warm, you're hyperthyroid. You know, anytime it's the woman that's going to turn down the thermostat, she's hyperthyroid. That just isn't how life works, okay? The next thing you're going to look at is this wonderful list of weight loss with increased appetite. Man, that just doesn't happen. There's only 3 conditions that give you that. Hyperthyroid, diabetes mellitus, because you can't use your sugar, and malabsorption. Okay? And then you get the other subtle changes of things like hair changes and skin changes that are smooth. But when you're talking about hyperthyroid, when you shake hands, it will always be a sweaty palm. If you shake hands with a woman and it's a nice, cool, dry hand, she isn't hyperthyroid. Okay? Hyperthyroid people get that total response. And then the next thing you can imagine is you're going to have this intimate relationship with the sympathetic nervous system. So this is where you get the tremors. This is where you get the anxiety. This is what everyone really hates. That's the one they really hate, is the anxiety. And then you're going to get all the mental and personality changes. After that, the next big one you want to talk about is cardiovascular, because this is where we get the arrhythmias. And the big idea here is if you're over 65, this might be all you get. So the big arrhythmia here is AFib. Then after that, we go to just to the general non-specific ones. So we're going to go to bone because they get osteoporosis, and we're going to go to muscle. And this is where you're going to get your muscle wasting and weakness. But you notice once you set up the story that to be warm-blooded, you need a thyroid system, and we regulate our thyroid regulation through the sympathetic nervous system, that really sets you up to think through, what are you going to key on in thyroid diseases? You're going to key on that ability to create heat and its relationship to the sympathetic nervous system. And then you'll always order it right for what are the best signs and symptoms. So when you come up and you say, which are the best ones I like here, right? I really like the idea that you know that that's what she hates, right? Losing weight with increased appetite, that's really a good one. And then when you talk about she's always warm. She is warm all the time.